Hello, everybody. Apologies for being a few minutes late. Are we all here? Brilliant. Sorry for that. Okie dokie. So welcome to this group where we are going to be looking at some hospital discharge work. If we want to just go to the next slide, we can whip through the next few and then we can get on to the presentations, which is what we're all here for. I'm Helen Lee and I work in the Experience of Partnerships team with the team who are hosting today. So thank you for joining the session this afternoon. If you don't want to be, the session's been recorded, so if you don't want to be on film, then please turn off your camera. And if you could just keep your microphone on mute, that would be fabulous, just to help us with speaking background noise for the speakers. If you've got questions, then please use the chat box and we will have time for questions and answers later. And there is closed captions available if that would be helpful. And there will be recordings of all the workshops on the NHS Futures platform. Next slide, please, Hayley. So this afternoon we've got two amazing presentations. We've got the Dorset Hospital Discharge project that's going to be shared, the carers experience, and then we've got Andrea from West Hertfordshire as well. So we've got a great session, as you can see there from the plan, time for questions and answers and for your reflections. And one of the things I've been tasked with is asking if to feedback something into the main room. So if you have any ideas on that, then please put those in the chat box and then we can use those to feedback to the main room. We can decide together. Next slide, please, Hayley. So without further ado, and I think we've made up our time, I will pass over to Anna to share the work that you've been doing with Harriet in Dorset Healthcare. Thank you.
Thanks so much. So yeah, hi everyone. Thanks so much for having us. We're really pleased to have this opportunity actually to share about what we've been doing in the project. And like Helen said, it's looking at that carers experience of hospital discharge and specifically when the person they care for is being in hospital. So I'm Harriet Stevens. I'm leading on the project and I'm joined by my manager, Anna Johnson, who's here as well. She'll introduce herself shortly, but we're just going to take you through a bit of the background to the project, how we've set things up, and some of the different ideas and pilots we're trialling, and some of the learning we're taking along the way with that. So I hope that's going to be interesting for you. So next slide, please.
Okay, so I think my job is to just give a little bit of a background, and I'm so pleased to see Helen here because she was part of the background really some time ago. But so back ever since really the pandemic, we were hearing so strongly from carers that discharge home from hospital had been really difficult for them and their cared for person. And I think before this project, we had been really successful at doing some small pieces of work off of the side of our desk that was to try to understand that experience a bit better through some engagement. So that both local authorities were involved in, acute trusts, us as the community health trust, and the VCSE. And then again through another project where we were encouraged to pilot some co-production and improvement, and that piece of work was funded by a NHS England project that Helen was involved in. And yeah, so that's the background to this, is an awful lot of persistence from a few people in Dorset, and predominantly from the carers in Dorset who were saying, actually, this isn't okay, it doesn't work for us, we need things to be a bit different.
Do you want the next slide?
Yeah, I can't bear saying next slide. It just reminds me of that awful man on the telly. Not an awful man on the telly, but that. Yeah, next slide, please. So what did people say were the problems during that piece of work? So they said that carers weren't identifying as carers, that they didn't understand why they should have to, what it would mean to them, that there were barriers for staff to carer identification, lack of clear processes, systems for where and how to record the presence of a carer. There was no time for conversations that lead to carer identification, and a lack of clear and consistent information for the carer about hospital processes. That there were really large differences between staff and carer expectation regarding either patient care and actually the relationship between staff and carers, and that the discharge process was complex with a fast pace of change, and that predominantly after hospital that the carer was missing in that handover. Next. Yeah, and there were some really clear outcomes of that initial piece of work, and that was around these themes really. So the need to have a more consistent way for the presence of a carer to be documented and handed over, for carers to be identified, for staff to be more care aware, have a better understanding of carers' needs and the value that carers can provide, for there to be better information for carers, for there to be clearer processes that everybody understood, staff included, and the one kind of shining light through the whole project was that although there's work to be done on culture, but actually there was a huge commitment from all to make things better for carers. So that's just a bit of a background, and I think, Harry, do I hand over to you now to talk about the real work that we're here today?
Yeah, I'm going to do the strands of the project.
Go for it.
Next slide, please, Hayley. Thank you. So yeah, building on all that engagement that Anna's just gone through and those insights that we gathered, it's really helped us shape the project that we're doing now. So this project is running across both our acute hospitals, so Dorset County and University Hospital Dorset, as well as our community hospitals, which are part of the trust that me and Anna are from, Dorset Healthcare. And what we're really aiming to do is use this funding to try out a range of carer-led quality improvement pilots, and that starting point being those recommendations from that insight work that came out in 2022. And I'll go a bit more into detail about some of those later to give you a flavour of those. But just to say as well, in Dorset County, we've got kind of a 2-council set up, so both BCP and Dorset Council. And when the Accelerating Reform Fund kind of came to being, which is the funding behind this project, each council had its own kind of approach of how they wanted to use the money. And that's actually been really beneficial because it's allowed us to kind of try different things and learn from different approaches. So BCP were really interested in looking at how volunteers can support carers, so that volunteer-led model, how they might support carers kind of during a hospital discharge, but also when they're back in the community. And actually Dorset Council wanted to build on some of the digital work that's already happening, particularly around the Bridget Care self-help platform. So expanding on that and looking at kind of new information and modules that maybe could go on there around hospital that will support carers at that time. Next slide, please. This is yours, Anna, on the guiding principles.
Yeah, and so although we've been working on it for a while, and some of the improvement work had been tough, one thing that we had managed to build and develop really well was really strong foundations in co-production through kind of carers co-production groups, and capacity, skills, understanding in quality improvement. So in improvement methodology, like it says there, is being curious, asking questions, and using that to follow the methodology to raise standards. And those were the 2 principles that underpin all of this work. So all of the work that Harriet's going to talk to you about, we are curious, we are monitoring, we are measuring where we can, and nothing is done without carers, nothing at all in this project. So that kind of underpins everything.
Thank you. The next slide. Apologies, this will be a bit small on your screen, but wanted to make sure I shared our theory of change model with you all, and you'll get a copy of these slides afterwards, so you'll be able to take a closer look at the detail. But for anyone who's not familiar with a theory of change, basically it's a way of kind of setting out your thinking of how you expect a change to happen, and it really helps you kind of map out the activities you're planning to do and the outcomes you hope to see and the longer term impact you're aiming for. And we found this really useful because it really helps us clarify what we're trying to achieve and the steps we think we'll take to get there, which I think is really important for that kind of shared understanding, support that co-production that's underpinning everything, and for everyone as part of the project. And it also forces you to be really specific and clear about the assumptions that you're making along the way. And I think another reason we did this quite early on is because it helps shape our evaluation. So thinking through what we'll need to measure and when, and how we know what we're doing is making an impact and we're making progress. Next slide, please. So on the next few slides, I'm going to talk through some examples of the co-produced pilots we were talking about earlier. And most of these, like I said, are really in early stages still. The project isn't super mature. We're under a year old at the moment. So it's all very much kind of stuff that's developing. But hopefully that will be useful going over some of these and what we're finding, what we're learning. So we've got action plans with each of the acute hospitals and with our Community and Mental Health Trust. And that helps us kind of share that good practice across the patch, but also really help support those hospitals to do things that actually they were already interested in doing and wanting to do, but just using this project to really back those up with a bit more capacity, resource and support. And this slide is about one of our pilot projects, which is around providing care awareness training to volunteers who are already active in the hospitals. So we know that raising awareness of carers in hospitals is a real challenge. The staff turnover is really high. The training they're being asked to do is packed, like the mandatory training, and people get a lot of messages and communication, which can be really overwhelming. And it just means it's hard to get any kind of core messages through. But at the same time, hospitals were kind of looking at how volunteers could play more of a role in supporting carers. And it's really been the coming together of those two conversations is where this idea has come from. So we already have around 1,000 volunteers roughly across our acute and community hospitals in Dorset, and many of them are kind of patient facing, they're on the wards. So we thought actually increasing their care awareness in the conversations they're already having and with the carers they're bound to already be coming across every day, whether they realise it or not, will potentially make an impact. And this isn't about giving those volunteers kind of extra responsibilities or creating new roles right now. It's just about shifting that mindset. They really do a good job at identifying patients who may have needs, but it's about helping them recognise that the person sitting at the bedside might also be someone with needs that might benefit from a bit of kindness, just a chat, a cup of tea. So it's just switching on that kind of carer mindset and creating that more care aware environment through the people we've already got on the wards and speaking to people. And as part of this work, we've had lots of conversations about being mindful of not to kind of overburden the volunteers. So we're not asking them to be specialists in carer support or have any specific advice that they're giving. So being really clear about that in the training we're delivering. But we've also developed kind of a simple tiered option leaflet for carers that they can hand out, which just explains what a carer is. And then that helps people identify as a carer if they feel they are one, and then choose the kind of support that would suit them. So it doesn't put that pressure on the volunteer to make that call. And most importantly, this training is being co-designed and co-delivered with carers alongside the staff. So we've actually got our first 2 sessions being run this week, Thursday and Friday. So yeah, carers are at the heart of shaping this and what this looks like. Next one, please. So the next pilot I'm going to talk to you about when it comes up is putting community volunteers in place to support carers during that transition from hospital to back home. because we've heard how important it is for carers to feel kind of held and supported through that period. But what's also come through quite strongly is that support really works well when it's peer-based. So when that volunteer has lived experience themselves, and that can be really powerful for that kind of empathy and trust. And it's just a different sort of support and connection that services bring. So this pilot focuses on a one-to-one support from trained volunteers who are also carers or have been carers in the past. And it was about creating a simple referral route from one of our acute hospitals so that their internal carer support service could kind of hand carers over to that community volunteer when their hospital support ends. And to do this, we partnered with a local organisation called Prama, and they felt like a really natural fit for us as they've already got some work that they do with the NHS, and they understand kind of the processes and the practicalities, and also they already deliver a whole range of kind of carer support in the community. So they've got support groups and they do carers training, and they've got other volunteer projects, so they can bring all that experience and that infrastructure that we can really build on as part of this pilot. And then the next slide, just talk to you about what we're seeing so far, and it's really encouraging. So we've done some recent surveys and feedback from carers, which have been really positive. I think there's a bit of delay with the slides, but it'll come up now. And they've told us that actually that continuity of support really matters to them. So having someone who kind of is checking in and understands their situation, is that kind of empathy, really makes a big difference, as well as that kind of practical support. Sorry, I think we've gone on a bit too much. Could we just go back one slide? Apologies. And then from the hospital.
Sorry, which slide can you see at the moment? I think there is a bit of a lag.
Yeah, you've got the ones with the speech bubbles. It's the one just before that is what the one I'm talking to. Sorry. Okay. Yeah, and from the hospital perspective, having that direct route to referring to Prama has been working really well. It's helped build that kind of stronger partnership, create those smoother processes. And we're really noticing that relationship kind of growing really positively. And the other thing that's evolved, I'll just keep that. Yeah, that's the one. Thank you.
Is that?
Yeah,
is
that's
that the right one. Sorry, they keep sticking a little bit. It's getting a.
Yeah, don't worry, no problem. Technology. Yeah, that's the one. And then another thing that's really evolved from what we originally kind of anticipated is that the referrals were only kind of set up to be from that internal care support service in the hospital, but it's expanded to be referrals coming from kind of other wards and other staff, namely the Macmillan unit, because actually they're also really care aware, they're really care friendly, they work really closely with families, so they're really well placed to identify carers and refer them on. And one other bit of learning has been that actually in many cases, the carers referred as part of this service, they've been quite complex. So there's been a bit of a need to have some kind of staff input from paid staff at Prama before kind of handing it over to a volunteer and before that volunteer can step in. And that's really useful insight as the project's kind of evolved. It's something we hadn't necessarily anticipated at the start. So all of this is kind of feeding into our thinking about what we do in the second year of the work and how the pilot can look going forward. Then the next slide just has some nice quotes in those, which I think you've probably seen now, about what carers are saying about it. And Wendy is one of the paid members of staff at Prama who does incredible work with carers and gets lots of positive feedback. So the slide after that, just talk about another piece of work we're doing. Thank you. And that's around developing the This Is Me document. I'm sure many of you will be familiar of this, but for those who are not, it's designed to capture like important information about a person. So their likes, dislikes, how they want to communicate and just what's important to them. And we've heard from everyone, patients, carers, families, staff, everyone, that this kind of information really, really matters. But at the same time, we've been hearing about the challenges with getting this across. So carers have told us that they're not always encouraged to fill out a This Is Me, or if they do fill it out, it doesn't seem to get looked at. And from staff, we're hearing that this document can feel quite long and clunky and unwieldy, and they worry about it being out of date and so the information not being relevant. And what's really brilliant in Dorset is that we're so lucky to have some really incredibly passionate lived experience who are completely driving this work, which is obviously such an asset to us. But it does mean we have to work quite hard to keep that staff voice in the mix so that whatever we actually create does work for everyone. And right now, where we are with this bit of work is we're focusing on improving the content of the document. So making sure that whatever the This Is Me asks feels relevant and it's clear and it's useful. And then the next step will be looking at the kind of process side of things. So how can we encourage the picking up of it, you know, the use of it? Because we know that won't be someone just telling someone to do it. It needs to be that it's meaningful and it will work for people in practice. And the very last bit I'm just going to touch on is it's a bit of a different example of something we're doing, because actually it's something we're a little bit stuck on, and I'm actually sharing it because if anyone does have anything, anyone in this room does have anything or an experience or input, we would really kind of value hearing about that. So when we did the initial work that Anna talked about back in 2022, even just within that relatively small group of people we engaged with and staff, we heard that there were 17 different ways that carers could be recorded. That's what you can see on the slide here. So it's clear that people are trying to document the existence of a carer, but despite everyone's best effort inside and across organisations, that information often doesn't travel with the person and it gets lost. And carers are telling us they have to kind of re-identify themselves and on every ward with every member of staff, every admission, and they're repeating their story time and time again. There is a long-term kind of ambition for us in Dorset and many areas, I'm sure, to have a shared electronic health record. And we'll hope that, you know, in the future that will go a long way to help with this problem, but that's not here yet. So in the meantime, we're really trying to figure out what we can do to help and what else might we be able to figure out in the meantime. And hospitals are working so hard on this. So we've had lots of discussions, but there's no real obvious quick fix that's coming to life. We've had a look at some carer flags and also trying to plug in some work that's already happening. So looking at the discharge planning, wider work that's going on, or documentation projects, and just making a case for carers to be properly recorded in that. And we've made a few steps forwards, but there hasn't really been anything that's completely unlocked this for us. So I'll wrap up there, and I know on your agenda you're going on to the next presentation, but yeah, when we do have kind of questions and feedback, I'd love to hear from anyone that's got anything around this particular piece of work or anything that's helped with that consistent way of recording carers, because that would be amazing. And then my contact details are just on the last slide, and thank you so much for listening.
Thanks, Anna. Thanks, Harriet. Brilliant. So just in the interest of time, if we'll go to the next slide, and we will pass over to you, Andrea. And if anybody's got any questions or comments, please use the chat box. That'd be great, and we'll pick them up from there. Thank you.
Hello, everyone. My name is Andrea Hone, and I am the Carers Lead Nurse for West Hertfordshire Teaching Hospital Trust. Next slide, please. I thought it would be a bit nice to start off with telling you about what inspires me as Carers Lead. So I have been in and out of caring for family members for many years on different levels. Here in the bottom left is Sally. Sally was my sister. She sadly died at the age of 31. She had breast cancer, liver and bone metastases at 27. She developed brain metastases near the end of a brave 4-year battle, and I cared for her emotionally, physically and practically. Sally really is the centre of how I empathise, listen and give time to carers. So although I didn't understand the term carer at the time, on reflection, I realised that this has really had a big part to play throughout my nursing career, that I've always been drawn to supporting families. I care for my fantastic in-laws on the bottom right in a variety of ways. Both had long-term health conditions and cared for both during COVID, and both sadly died during this period within a year of each other. To the top right corner, my wonderful strong dad and my mum. He had mixed dementia and passed last year after 18 months of being diagnosed. I supported my mum to support my dad. And I really had a huge insight on carer breakdown, as my mum, who was 82, just declined any additional support or help until the end of his life. So this was a very difficult and challenging, really, time to try and navigate, even in the role that I am in. And lastly, in the top left-hand corner is my two amazing children, and I share this honour with my partner of 21 years. I'm not an unpaid carer to them, but they inspire me every day, make me always want to strive to be positive, be a good role model, and keep me grounded. And they definitely make me laugh on a daily basis. Next slide, please. So I am here to talk to you about our Caring for Carers service and how we support carers along the admission pathway through to discharge. So in 2021, the opportunity arose to be part of a carer discharge project, which was funded by the Commitment to Carers team in NHS England. We were lucky to get match funded within our county council, which really supported us to continue with the work following completion of the project. We explored identification of carers coming into our frailty unit, and we looked at how we could support their needs as a carer from their admission to discharge, which was either straight into the community or through the inpatient pathway. And we looked at ongoing support in the community for the carer. On the back of this, we reviewed themes of how we supported carers during the project, and with carer feedback of what mattered most to them, and from this, our service was created. Next slide, please. So this slide really makes me quite proud, because when I came into the role of carers lead, I very much felt alone in my role. Our carer service sits under patient experience within the corporate division. Following our project, we had a full-time carer coordinator for 12 months with the external funding. But following that 12 months, a business case got approved for a substantive full-time carer coordinator to support the service alongside myself. With executive buy-in and support from the senior leadership, we've managed to secure further funding very recently for a second carer coordinator, who started at the beginning of June, with the aim for this to become a substantive role. We have our first carer volunteer, who actually started 2 weeks ago. She actually used our service, has amazing lived experience, and she approached us to ask if she could volunteer. My priority really was to get the trust on board first with the financial aspect of funding the team. But as things are moving forward with that, I really felt it's probably the right time to get a carer volunteers to be able to complement the service. We've had a temporary support with admin as the demand for the service is growing, and we're currently exploring ways of permanent support. We have a monthly carer dashboard report, which feeds into governance teams and our patient experience group, alongside sharing the carer dashboard externally to key stakeholders on a monthly basis. My role also feeds into staff experience and the EDI team to support our working carers, and our service is a good point of contact for our own staff who are in a caring role to gain support. Next slide, please. So this slide really shows how the referrals into our service over the past 3 years has risen, and the demand for the service is growing. We also measure interactions that we carry out when we support a carer in some way. If we get less referrals 1 month, we may still have a high interaction level due to carer complexity. So we feel it is important to reflect this as well. Next slide, please. So now a little bit about our service. So we are a Monday to Friday service that runs between 8 and 4. Our aim is to follow the carer through their pathway, offering support in accordance with their needs. We cover all 3 main hospital sites, but we are physically based at Watford General Hospital. As well as supporting our virtual hospital, we support carers of any age who may be a patient themselves or supporting a person who is a patient. So in relation to discharge, our aim is to have a carer identified at the earliest point of the hospital journey so that they can be supported, and for them to work in partnership with our hospital teams so they can be involved in patient discharge. This slide represents the types of support that we offer, which includes a lot of support around discharge planning and involvement for the carer. We do find that carers can feel pressure from the hospital to get the person they care for home as soon as possible. Carers can feel pressure from the person they care for to get them home as quick as possible. The carer will be faced with many decisions. The carer may be considering taking on this caring role for the first time and don't know what to expect. Or they may have already been caring for the person, but their needs have now increased or changed. Some carers may need very little support from us and may just want to know what support there is in the community and need guidance to navigate this. Or we may have very complex cases where carers need a lot of emotional support when coming in as either a patient or a person supporting a patient. Carers may wish to stay in for hospital for longer periods during the day or night to support their loved ones, in which the ward will complete a carers agreement with the carer, and our service issues a carer bundle in receipt of this to ensure they're being looked after. We provide emotional and practical support to help carers navigate their journey in the hospital. We try to advocate, empower and support communication and be a direct point of contact for them. Next slide, please. So we receive direct referrals in which we accept emails, paper referrals, telephone referrals. I have highlighted our timescale for initial review. So if a carer is hugely overwhelmed, nearing carer breakdown and/or is very emotional, we will aim to see them within 1 to 2 working days. We review our carers supporting a loved one near end of life for the same time frame. If we've been referred a carer who has a carers agreement, we will also aim to review them in that same time span. If a carer referral is non-urgent, we aim to review them within 5 working days. Also, if a carer has been discharged from hospital, for example, from frailty or the emergency department, or we have a referral from outpatients, we're really happy to follow them up if verbal consent has been gained. All carers that we are referred will initially receive, not quite there, yeah, but it's fine. All carers that are referred into our service will initially receive a carer resource pack. So this includes our service details. It has tips to navigate the hospital pathway and discharge advice. We have useful contact links to the community, such as Carers in Hearts, our local care organisation. We have a bit of carers' rights, carers' assessment and contingency planning information. Next slide, please. So I feel this slide is really good representation that we are slowly chipping away at culture in terms of identifying carers at our trust. There is now a real breadth of people and services that refer into our service. When you compare before even the service began as carers lead, I might get not even 3 to 5 referrals a month. So we really are stretching our service around the hospital and people are really getting to know and find out about us. Along this, we get many referrals from discharge coordinators and the discharge planning nurses who are recognising the support needed for carers, and we work closely with these teams. We also get a lot of self-referrals by carers themselves. So recently we updated our trust webpage, which has a huge amount of information for carers and the support we offer at our trust. And it is noticeable that carers really are contacting us more. We also get carers calling us that have previously been supported by us. And they'll recontact us if they are coming back to hospital for themselves or for the person they support. Next slide, please. Hayley, if you could kindly play the video. This is a short video from a carer who we have supported. Just gives you an idea of her perspective, the impact of our service. If it plays.
Can you hear that?
No.
Right, I might just need to reshare. Sorry, just a second.
parents with me, not just the one that's injured or unwell. And it's a stressful time, and I need to be really steady within that. I can't be the one that's stressed because I've already got to deal with one or both parents. And that's where Andrea and her team come in. They deliver absolutely amazing support, something that varies from the practical, so bringing a thermos flask when you're stuck with your parent, you can't leave them, but you still need to be looked after and to look after them. Meal vouchers so that you can make sure that when you're on a long day, you do get something to eat, and they help keep you going. They also take away worries, things like parking. You've got the vouchers, and the simple lanyard enables you to not have to keep explaining who you are and why you're there and that you need to be involved. But the main thing is feeling that someone is alongside you. They're a guide. Hospital practices, particularly say discharge expectations, they can help you to know what to ask. They're a friend alongside. You can ask the questions you wouldn't want to ask the professional nurses and doctors. You want to take their time. They're a champion for you. They help you to feel confident as to who and what to ask. And they're this sort of trusted anchor, really, as you navigate this sea of unfamiliar faces, places and processes. They just help to create calm in anxious times. So thank you.
Thanks, Hayley. Next slide, please. So our trust has recently been involved in the development of a carer discharge group, which is led by Hertfordshire County Council, comprises of relevant leads within our acute trust, which is our trust and East and North Hertfordshire Trust. Also our integrated care board and Hertfordshire County Council to engage directly with carers to record and understand individual experiences of hospital discharge in Hertfordshire. So the idea is collectively to develop any learning and recommendations for improvement following this. Our first group of carers to talk about their experience was actually this morning, which wasn't great timing, but there we go. So the next step will be that the case study will be presented to the carer discharge group, and we will go from there. Next slide, please. So I previously talked about how we receive referrals. However, the next step is to have a formal place to identify a carer on our electronic patient record. Currently, a carer may be documented within the social history or the notes at the time of review of a patient, but can easily get lost and not seen. So we now have a carer tab on our test site, and we are formulating and trialling different flows of how this is structured within the digital system and how this will flow from the emergency department to inpatient documents. When a patient is identified in hospital, we will be having an automated daily report of carers identified once we have that system in place, so that our Caring for Carers service will flag them on the system. We're just currently scoping our SNOMED codes on our system to identify both is a carer and has a carer. We aim to use this recorded data to work with the integrated discharge team to ensure carers are involved at the earliest point for discharge planning. We aim to use the SNOMED code flag alert so they can transfer onto the discharge summaries sent to GPs, so that if a carer is identified in hospital, we can transfer that information to the GP. We are currently awaiting our carer referral to be placed on the system, but we will continue to take all current modes of referrals still. And also discussions have begun to look at restructuring and templating our carers agreement onto the system to be formally documented within the patient record. Next slide, please. So I am currently in development of our hospital's digital carer survey. This will allow us to review live anonymised feedback, but will give us the ability to understand the ward or department the carer's experience was from. So within the survey, we will incorporate questions using I statements, which were developed in the community by carers within the discharge section of the survey. Each question will be scored, which will show us what we as a trust are doing well at and what we require to improve. So we can share and learn and work with the wards to take ownership of that survey. Next slide. That's it, I think. So I'm going to finish here, and just to add that it has been really lovely to be able to have time to reflect on our journey at our hospital, and really appreciate the opportunity to have had the project funding which started our service. Thank you.
Brilliant, fantastic. Both brilliant presentations and really insightful there. And there's been a few questions in the chat box. I don't know if anybody's got a question that they want to ask. I'm just mindful of time because Steve's told us we need to be back in the main room by past. But I've been keeping an eye on the chat, and there's a few in there. Andrea, just some quick ones. People have asked if you'd be happy to share your resources. What platform digital platform do you use?
Yeah, Equivia we're using.
Thank you. And somebody else has asked if you would be happy to share, if you've got a web page that you could share a link in the chat so that they can go and have a look, because they're really interested in that.
No problem.
And Darren's asked a question around how would you reach and support all carers? Andrea, you know, what would be your magic top tip if you could?
We have the Healthcare Partnership Board in the community, which we will be looking at health inequality. So that's a fairly new thing that I'm trying to infiltrate with, so we can broaden our reach. I've done a listening event for young carers, but obviously I have to not prioritise, but gauge how much I can do in a year, and that is definitely within Q4 to be able to start moving with that project. So I'm really aware that it is such a big project. So they're just a couple of things.
And Andrea, I was just really coming from the context of like I speak to like people that do amazing work like you all over the country, right? And everyone's like one or two people, like in the whole of Birmingham across 4 trusts, there's 2 people providing like carer support coordination, and being able to create advice packs, listen to carers, get out and train departments on how important it is to actually identify and support carers. It's like an impossible task, really, because you'll have 100,000 carers engaging with the hospital. You can't support them all. So I just love to maybe separately have a sit down and talk about how we could maybe look at improving that. I think the simple stuff,
really
like, like you're talking about, like, how do we identify the carers up front? If GPs did what they should do and we coded carers effectively, and then at the point of admission, that information is shared into the acute, then we'd know. And it seems like it's a simple fix. So why don't we just speak to the ICB and get them sorted out?
Yeah, really happy to have a chat.
Thanks, Andrea.
Brilliant. Janice, have you got your hand up?
I have. I'm trying to unmute myself. I think I've done it.
Yeah, we can hear you. Yeah.
In answer to that last question, I think the more information you can give to carers about what they should expect at this time, and if they don't get exactly what they expect, sources of support such as the PAL service and the carer support, leave those for people who need the more intensive support. I think we need to empower carers more. It's, as the earlier speaker says, you cannot support 1,000 carers, and it's all about good training for staff, good empowering information to unpaid carers, support them to self-advocate, support those who can't.
Thank you, Janice. Brilliant. I am just conscious of time. Hayley, could you pop in the chat the evaluation link? And if you could just fill in, we would really appreciate you just taking a couple of minutes to give us some feedback, then we can go from there. And I will come to you, Ross. You got your hand up.
Thank you. Just one point. In Norfolk, we've just launched, or just piloting, a carer booklet for a sort of, I like to call it in and out of hospital. It's really for carers to know what they can expect and what they should expect as the people for whom they care are going into hospital, resources for them as they come out, people who they could contact in Norfolk. It just seems to me that the onus is always on the carer to make the contacts, to find out. The education of the professionals in the acutes, we have 4 acute hospitals in Norfolk, I think is very difficult. We have tried, and there is a great willingness, but it just does seem that it takes a long time for for the message to get through. But we are, as I say, piloting this carers handbook in one acute hospital at the moment. So it would be interesting if anybody else wants to know anything about it, get in touch with carersvoice.org in Norfolk.
Brilliant. Thank you so much. I'm really conscious of time and that we need to jump back into the main room, but I just want to say a massive thank you to Harriet, Anna and Andrea for really showing the great work that's happening and how you can make a difference. And I'm loving your QI approach and your co-production with unpaid carers, which is just making sure that it's designed right. Brilliant. Thank you so much, and I will see you in the main room. Thank you for joining us.